Hello, good evening, and welcome to the very first SCA UK live here on the Sudden Cardiac Arrest UK YouTube channel. My name's Gareth Cole. I'm one of the trustees of Sudden Cardiac Arrest UK. I'm a two-time out of hospital cardiac arrest survivor, and I will be your host for this evening. If you're watching on YouTube, feel free to utilize the chat. Do give us a thumbs up, say hello, let us know you can hear us. Definitely let us know if you can't hear us. And feel free to ask any questions throughout the evening that you want to ask. Tonight we're going to be looking at some of the questions that were raised by our community prior to the 10 Years Together conference that we held in Hinckley just a few months ago. And I am joined this evening, I'm not going to bore you to death all on my own. I am joined this evening by my good friend, my co-host and my partner in crime for SCA UK Live, the fabulous Joanna Balgarnie.
Hello there.
There she is. Hello.
I like being fabulous. That's great.
And we're also joined, of course, this episode is called Ask the Cardiologist. So it would be handy to have a cardiologist, and we most definitely have. So we are joined also this evening by the cardiologist formerly known as Dr. Tom Keeble, now Professor Thomas Keeble. So Tom, there you are. Welcome, good evening.
Welcome, hi everybody.
So the idea this evening is we have some questions which we pre-selected. I'll let Joanna talk a bit more about that from the conference. All the questions tonight are related to cardiology. We will have other events coming up later where we talk about ICDs, we'll talk about psychological aspects, all that kind of thing. Tonight we're concentrating on cardiology. We'll go through a couple of questions. We'll have a chat about them. You can ask any questions you want to ask about those questions or about those answers. And of course, you can ask questions of myself and Joanna if you want to, although I suspect you're more likely to want to hear from Professor Keeble. Yep. You can ask any questions that you want to. Bear in mind, answers are going to be reasonably generic. Professor Keeble doesn't know your particular medical history. He doesn't know why you're on 20 milligrams of something and not 10. He's not going to be able to give you specific medical advice, but he will be able to give generic answers. I think that's right, Tom, isn't it?
It's very fair, yeah.
So we shouldn't assume that everybody knows who we are, even though I've done a quick introduction. As I say, I'm Gareth Cole. I am one of the founder members and trustees of Sudden Cardiac Arrest UK. Joanna, would you like to just quickly introduce yourself and tell us who you are and why you're here?
Yeah, sure. Hi, I'm Joanna Balgarnie. I'm one of the trustees. I am also a cardiac arrest survivor now of 11 years. Had my cardiac arrest in my sleep. Shall I just give an explanation of the background to the question here, Gareth?
Yeah, absolutely.
That'd be helpful. Those of you in the Facebook group will know that earlier in the year, before the conference, I put out a series of what I call big questions. And this was one that got our most impassioned responses, should we say. And it was quite simply, if you could ask a panel of medical professionals one question about life after sudden cardiac arrest, what would it be? And this is, we answered some of those questions at the conference, but what we like about this is it gives everyone else who didn't attend the conference the chance to both hear those answers, but also ask more questions if they want to, which is why we have Professor Tom here with us.
Yeah, and Tom, would you like to introduce yourself and tell us who you are, why you're here, how on earth you got involved with this Facebook group that got out of hand?
Of course, yeah. So I'm Thomas Keeble. I'm a cardiologist at the Essex Cardiothoracic Centre, and I think about at least 10 years ago, I started doing clinical trials in cardiac arrest patients, trying to understand how we could improve outcomes. And then I became interested in following up of patients and the challenges that they had, and realised that the follow-up care was extremely suboptimal across the UK and within our region. And so put a lot of work into supporting patients, developing new services, support pathways. And for the last decade, I've really done that in association with Southern Cardiac Arrest UK. And I am a trustee also of Southern Cardiac Arrest UK, which is an incredible privilege. And to be able to work with such an amazing group of survivors and co-survivors, allows us to move forwards and improve treatments for patients with sudden cardiac arrest in the UK and beyond. And so, I'm a practicing clinician. I'm a practicing academic, and one of my major academic interests is academic research within cardiac arrest to improve outcomes and to measure outcomes, and setting up novel clinics, novel information sharing, and events like this where people can have access to information, because a lot of what patients want nowadays, and rightly so, is access to the right experts, access to information, because there is a lot of misinformation out there and people can sort of get the wrong end of the stick or have the wrong end of the information, via Google or via other AI portals. And it's really important that we link survivors and co-survivors up with real believable, trusted source of information, and Southern Cardiac Arrest do that better than anybody.
Fantastic. Thank you very much, Tom. And also thank you for being here. Thank you for finding the time to come and join us this evening. Guys, I should have said earlier on, but I'll say it now. If you do want to ask a question of us in YouTube chat, see if I can bring it up. There we go. If you could tag us at SCA UK in chat, and then we will try to answer as many questions as we can. We don't know if we're going to get 2, in which case we'll answer them all, or 200, in which case obviously we can't. But we'll do our best. But if you don't know what I mean by tag us, just start your question with at SCA UK, then a space, and then ask your question. Otherwise, everything gets lost in the ether, and we can't follow it.
And actually, Gareth, we have a question here from Brian. I don't know if you've seen it, which I think actually is better if we start with Brian's question straight away. I think that's a really good way to start, actually. You've got it up there.
It's the perfect start, I would say, because there's still a lot of, there's huge amounts of misunderstanding of this in the lay press, let's call it. So shall I launch into that then, Gareth?
Absolutely, yeah.
Yeah, okay. So a cardiac arrest is, in essence, when the heart loses output, or the body loses cardiac output. So we're all aware that our heart is beating when we're resting 60 to 70 beats per minute, when we're exercising maybe 120, 130 beats per minute, with a blood pressure of say 125 over 80. And it's supplying blood, oxygen, nutrients to our brain, to our kidneys, to all over the human body to allow it to work and allow us to be conscious. What then happens when you have a cardiac arrest? The heart stops, or effectively stops. So there is no useful output of cardiac output, of oxygenation, of nutrients going to any of your organs. And of course, the most important organ that we all own is our brain. So as soon as your heart stops, for whatever reason, and we'll probably talk about some of those later, then you generally pass out because there's no blood going to your brain. And to all intents and purposes, you are unconscious, comatose. And if you do not receive a basic life support immediately, you will die, because if you do not resuscitate someone whose heart has stopped, then the inevitableness is that they will die. And so it really is of paramount importance that we identify patients in the street, in the airport, in our homes, wherever it occurs. And bear in mind, 75 to 80% will occur in the home. It's really important that if we can be trained in CPR and basic life support, that we can identify when a patient has collapsed to the floor and when a patient has lost output and requires immediate CPR, calling for help, ambulance, defibrillator, and then the sort of package of care that comes from emergency ambulance treatment. Now, where cardiac arrest, as we've said, which is when the heart stops for whatever reason, it does in the lay press and in many sort of quarters get confused with a heart attack. So let's just talk about what a heart attack is. A heart attack is when the blood supply to your heart muscle is compromised. So most of us have three major coronary arteries supplying our heart with blood: a left one, a right one, and a middle one. And if any one of those three gets suddenly blocked with a clot-like problem in one of your arteries, you will get chest pain, you will feel unwell, you will get sweaty and horrible, you will look grey and clammy, and you will be having a heart attack, and you will seek medical attention because you feel ghastly, you've got chest pain, and you would call an ambulance. But I hope that, as I talked about with cardiac arrest, those two are very different. Cardiac arrest, sudden unconsciousness, heart not pumping, requires basic life support, CPR, potentially defibrillator, and urgent paramedic and other help. A heart attack, of course, is a conscious patient generally, where they are talking, sweaty, feeling sick, saying, "I've got terrible chest pain, I don't feel very well, can you get me an ambulance, please?" So the two are very discrete, very different. However, and this is where the confusion sometimes comes from or stems from, is that a heart attack, unfortunately, can cause the heart to stop. So you could start with a heart attack with a blocked artery, conscious, talking, with chest pain, feeling unwell. And that, I'm afraid, in time can progress, that the heart stops working because it's had so much lack of blood supply and is so unhappy. So I think that's where a lot of the confusion comes from. But Brian, it's an excellent question. Many people get it wrong, and it's really important that you differentiate between having had a cardiac arrest and having had a heart attack. But of course, you can have both. And actually, the commonest cause of cardiac arrest, and this is where the confusion comes from, is a heart attack. About 50% of those will be related to having had a heart attack, causing the heart to stop and go into a very chaotic rhythm. I hope that clears up that sort of simple challenge between the two, because it is something that certainly, as I say, a lot of people in the media do confuse.
Can I just intercept there? That was a fantastic answer. I've learned stuff already. Thank you very much for that, Tom. The way that I always see it as a layperson, as a just an observer, is that a cardiac arrest is an electrical problem and a heart attack is a plumbing problem. Would that be right?
I'm afraid not. No.
Well,
the trouble is, if your cardiac arrest,
from it could be one going to the other one.
Well, let's think about it. Let's think about the heart problems first. So the heart can do one of two things. It can go into what's called ventricular fibrillation, which is when it just wobbles. So normally it would pump vigorously in a contractile, coordinated manner. But when it goes into ventricular fibrillation, it just wobbles. And that's why it needs to be shocked back into normal rhythm again. So that's why the defibrillator saves so many lives. But it only saves the lives of those patients, and it will only advise a shock in those patients who are in this rhythm where it's fibrillating, where it needs to be shocked. Let's think of a different reason why you might have a cardiac arrest. Let's imagine all of us suddenly have a big clot go to our lungs. Clot forms in our leg because we've had a viral illness and we've been stuck in bed for 4 days, we're dehydrated, and a big clot from my leg goes up and lodges in my lungs, okay? And it lodges, and it's so big that it blocks my main artery in my lungs so that no blood can get around my lungs and around my body. That would make me have a cardiac arrest. So nothing to do with the heart muscle, nothing to do with an arrhythmia, nothing to do with a cardiac inverted commas problem, but a clot wedged in my lungs that just means my circulation cannot go around my body. It just comes to a complete halt. And I'm afraid the end result would be a cardiac arrest. So people can die from sepsis, from a really nasty infection. People can die from a pulmonary embolus in their lungs. So a sort of non-cardiac pathology. So if we separate them, let me go back one step to go back to where you were at the start. So you're absolutely right. The bottom line is when you have a cardiac arrest, the heart stops or cannot pump. That's the first thing to say. And it can be because it needs a shock and it's just fibrillating, or it can be because of other conditions. And
Right.
the ones that are where it's physically wobbling, it needs a shock. But all of the other ones, it needs CPR and doesn't need a shock. And about 50% of patients won't need a shock because actually it needs another treatment, whether it's a clot buster to break up the clot, whether it's some fluids because the patient's profoundly dehydrated, or lots and lots of other sort of more medical reasons other than the heart alone. So I hope I haven't confused and muddied the waters even more. But the bottom line is that almost anything can cause a cardiac arrest, but the common things and the common two reasons are a heart attack, as we've talked about, leading to a cardiac arrest, and a primary arrhythmia where the heart has a muscle type problem, maybe genetically, and then goes haywire into this fibrillation, which requires a shock. And those patients can be completely well until all of a sudden they just collapse to the floor. And those types of patients are the types of patients who would need a defibrillator because they've got a heart muscle condition. They go into this horrible rhythm. They collapse to the floor and to all intents and purposes die, are then resuscitated. And to prevent that from happening again, they'll need a combination of medications, but a backup ICD defibrillator so that, God forbid, that were to happen again, they would be protected. Does that make sense? So I think the trouble is that cardiac arrest is such a varied group of conditions. And I think that's one of the problems why lay people, in a way, understandably cannot understand all the different causes because they are so many. And I think sometimes there isn't a one size fits all. People do have, and sometimes even in ourselves, we're unsure as to the underlying pathology or the underlying, and we make our best guess, for want of a better word. But the causes of cardiac arrest are varied, but essentially plumbing problems, you're right, will cause ventricular fibrillation with a heart attack, and heart muscle problems, often genetically developed, will also cause this ventricular wobbling that needs defibrillation. So, as I say, it can be challenging because there are so many different causes, and we have to keep it a relatively sort of high level so that we don't completely and utterly fox everybody.
Great.
Thanks, Tom. That's fantastic. I just quickly want to say, Sarah or Sarah, I do apologise. I don't know how to pronounce your name. I have seen your question. I'm not going to ask it immediately because it's actually a brilliant follow-up question to one that we're going to look at very shortly. So if it's okay with you, I have got your question. I will ask it. But it would be better to tag on to the end of another one. So we had 3 questions lined up. I don't know where they are now. Shall we crack on with number 1 and let Tom have a swig of his coffee to get himself back into action? And let's see if I can bring that up. So question 1, which was asked before the conference. Why are SCA survivors often placed on a standard set of medications without individualized assessment? I mean, that's a statement as opposed to a question, or it's bordering between the two. It presupposes that survivors are placed on a standard set of medications. But Tom, do you want to tackle that one?
Yeah, of course. So I think the reason, let's go back a step. The most cardiac arrests are caused by heart attacks. That is the majority, about 50% in our centre. So you could imagine, therefore, that if 50% of all cardiac arrests are caused by a heart attack, you need to treat all of the underlying risk factors of a heart attack so that this doesn't happen again. So you can therefore imagine that I think the question is slightly unfair, because I think what we have to reassure you is that everybody's treatment is individualized, to be perfectly frank with you, and it will depend on the cause. But of course, when the largest cause is a heart attack causing cardiac arrest, then you would expect, therefore, those patients to get the same treatments because they've got the same underlying problem. So those treatments are going to be a number of things. Firstly, you're going to almost certainly have aspirin because you've had a heart attack, if you have had one, and you may well have had a stent as a result of that to make the blood supply better to that part of the heart. When you give aspirin, you generally, when you put a stent in, have to give super aspirin, which is clopidogrel or ticagrelor or prasugrel. So there's 3 of them, but you will need one of them, usually for 12 months, in addition to aspirin. So everyone who has a heart attack plus or minus a stent is going to get aspirin and super aspirin. In addition to that, they're going to get their cholesterol lowered by whatever means is required. So that usually in the vast majority of patients means some form of statin therapy. Very good evidence, reduces inflammation, reduces your cholesterol, reduces cardiovascular risk. The next bit is then related to heart function. So when you have a heart attack, it is inevitable that parts of your heart muscle die. And when parts of your heart muscle die, your heart becomes weakened. And when it's weakened, there are essentially 4 medications that will make your heart stronger over the time of your life, the rest of your life. They include a beta blocker, which lots of people are on and a number of people get side effects from. Something like an ACE inhibitor like ramipril or perindopril or something like that, which stop the heart getting scarred and lower your blood pressure too. Then there's a drug called dapagliflozin, which was historically a diabetes drug, but is brilliant in heart failure at preventing people from dying and from coming back with heart attacks and death. So it's a good drug. And finally, there's a drug called either eplerenone or spironolactone, which are really good at making the heart pump better, having less arrhythmias long term, and preventing you from having essentially bad outcomes long term. So you can see that if you've got any reason to have bad heart function, you would want to be on those 4 tablets, all 4 of them, because they're going to stop you coming back and stop you having complications and problems of your cardiac arrest because of your heart function being poor. And if you have a heart attack and a stent, then you're going to have aspirin and super aspirin for 12 months. So everybody in that scenario with a heart attack and a stent and a bit of heart function problems, which you will have inevitably, you're going to go home on 6 tablets sort of without even breaking sweat. That's kind of inevitable. And then you may need something more in a kind of more individualized or bespoke way on top of that. So you could end up with 7 or 8, but it's not because we're trying to poison you. It's because we're trying to follow evidence of randomized controlled trial where thousands of patients have been put into a placebo group or into this active drug group. And it's been shown that these drugs are beneficial to patients. And so you kind of have to trust your physician, trust your cardiac center, trust your cardiologist that we've got your best interests at heart to have you. And if I had a heart function that wasn't normal, I would want to be on those 4 tablets. And if I wasn't, and we call them the 4 pillars of heart function treatment, if I wasn't on those 4, I'd want to know why. Does that make sense? Because that is the standard of care that you should deserve and you should expect. So going back to the question, why are sudden cardiac arrest survivors often placed on a standard set of medications? Well, if they've had a heart attack, the treatments are relatively standardized. And so if you've had a heart attack, you will get aspirin, super aspirin, and those 4 tablets to make your heart function better. Now, of course, if your heart just has a little bit of scar and you've gone straight into a shockable rhythm, then your coronary arteries may well be pristine. So potentially, you might not need the statin, you might not need the heart pump function drugs, but you probably would still need the beta blocker, maybe some blood pressure control, and potentially an ICD. So I think to sort of just query the question slightly, I think we are always trying to personalize and individualize patient care, and you have to trust us that that is what we are trying to achieve. But at the same time, whenever the heart function is not normal, there are 4 tablets which everyone should get, and that is why. So it really is entrenched in evidence that we do this, not just sort of as a sort of off the bat, you're going to get this whether you like it or not. I would want to be on all of those if my heart function wasn't normal, and very often heart function is not normal after a cardiac arrest.
Can I come in there again? A fantastic answer. One of the questions that we have quite a lot Tom, is about review of medications. So I totally see the logic of people going on to those based on evidence, based on that they've got the common underlying issue, and the early treatment is vital, and you need to get those tablets and them under that care. After how long do you think is it fair for people to perhaps come back and say that they'd like to speak to their cardiologist or their GP or whoever you think is the most appropriate person to then say, do I really need all of these? Could you just explain it all to me? Could you review it because I'm terribly tired, or blah blah blah? What some people are worried about doing that. Some people are worried about following that thing that you said at the end, which is to trust the GP, to trust the cardiologist. We do trust you, but also we know our bodies as well.
No. I don't. So don't get me wrong. I think the trusting and knowing your body's thing is really, really important. I think, as you all know, who are on this webinar, fatigue and tiredness and brain fog is sort of the number one complaint of cardiac arrest survivors. And in fact, anybody who has any degree of brain injury, whether it's due to a cardiac arrest or whether it's due to a stroke or a TIA or anything like that, and it can be brutal. And so sometimes people are blaming, I think, the drugs, which it's often not. But to go back to your question, I think very commonly, and we see this a lot in our region, general practitioners don't feel able or skilled or whatever you want to call it, empowered enough to want to make these changes. And so I think it does lie with a combination of asking cardiac rehab, if you've got access to cardiac rehab, who generally will have access to cardiologists on a daily basis. Certainly I get a lot of questions from cardiac rehab. And I think you're right. Access to your cardiologist nowadays is not very accessible. It's difficult. It's challenging. You know, the first time you might see me might be at 12 months, and that's it. That's actually a lot. And so I don't think that's right. But unfortunately, in the NHS, that is the reality. And actually, to have an appointment with me at 12 months, many centres across the UK don't do that at all. They just have cardiac rehab and a pharmacist follow up. So I'm not suggesting for a moment that is right. But I think that for me, I think that it depends if you've got a problem or a perceived problem with the drug. I think if you've got a perceived problem with the drug, you need to seek advice as to which one maybe it is that could be causing the side effects you're having, and which one it might, because most of these drugs, you can safely change them to something else which has equal benefit. Does that make sense? So there's loads. So let me give you a couple of examples. Ramipril, for instance, an ACE inhibitor, gives people commonly a cough. About 10% of patients will get a dry cough. If you switch that drug to losartan, you will never get a dry cough, and it does exactly the same benefit. And so that one is a real straightforward switch of which you're going to derive the same benefit, but you're going to get rid of your cough really quickly. Beta blockers, similarly, beta blockers are brilliant drugs for heart attacks, for pumps that don't pump so well, and for arrhythmias. But some people don't get on with them, as you say. But there are alternatives that can have almost as much benefit, but not have those difficult side effects. Same with statins. About 5% of patients, statins have a bad name, which is extremely unfair on them because they save millions of lives across the world every year. They do a brilliant job at getting your cholesterol down, and they do a brilliant job at making your arteries less inflamed so that you won't have as many heart attacks and strokes in the future. But they get bad press in the Daily Mail and others, but there are alternatives. So if you have crippling muscle pain from cholesterol tablets, statins, I would not make you continue. I would say, look, this is your statin. Let's stop it and let's give you something else. There are 4, 5, 6 different medications we can give that can derive you that benefit of lowering your cholesterol, but not give you the muscle cramps or whatever side effects you're getting with statins. So it's a really, really good question, but it's an access problem that we've got. It's nothing more, nothing less. And it's a education problem that we've got in general practice, in that they don't feel educated and sufficiently, some of them, let's not talk about all of them, some will be brilliant in certain areas, but many GPs don't feel that they have the knowledge and the skills because they can't be experts at everything. Can't be experts at cardiac arrest, at stroke, at cancer, at this, at that. There's so much for them, in their in their clinics that they see, day to day, from a kid to an adult to an old person. There's lots and lots for them to learn. So, in summary, If you believe that you've got a significant side effect to one or more of your drugs that you have been put on following your cardiac arrest and since you've gone home, number one, speak to your cardiac rehab if you're offered it. They're very capable at supporting you to work out which one and how to go about changing it. Two, go and see your general practitioner. And if your general practitioner can't support you and help you with changing it to a different one or trialing a different medication that does a similar type of role, then we would generally be very happy to have this advice and guidance when they send us an email and say, Mrs. Jones can't tolerate her statin. What do you suggest, doctor? And we'd say, we would suggest X, Y, or Z. But you should not suffer in silence. And the worst thing you can do is just stop everything, because it makes you feel better, but you're then not getting the benefit of the long-term prevention. And then that has its own challenges. So I think, and people do stop the aspirin, people do stop the super aspirin. But the trouble is when they do that, they come back with a block stent, and that can be incredibly life-threatening again, unfortunately. So we just need to be mindful of that. But I do think we need to upskill GPs, and we need to give you better access to us so that you can potentially make better informed drug decisions and switches at an appropriate time.
Fantastic.
Well, Tom, can I just ask, who makes the decision in the first place? Whether, for example, a patient gets ramipril or perindopril, which is, to all intents and purposes, the same thing.
It is the same thing, yeah.
Centre by centre, is it doctor by doctor? Who makes that decision on day one?
Yeah, there are sort of let's call it preferred hospital directives, i.e. that our standard sort of 4 drugs, going back to those 4 drugs, is A, B, C, and D, so to speak. But the honest answer is it probably is down to the consultant of the week who sees you on that ward round on that Monday, or when you've come out of intensive care on the Sunday. And it is down to personal preference of what people believe to be the right one. I tend not to use ramipril and perindopril anymore because it does have a 5%, 7% cough rate. Whereas if I give losartan, I'm not going to see that. They're the same price. They do the same thing. The data is as good for one as it is the t'other. So I would tend to do things very slightly different to colleagues, but I guess slight variation in practice is inevitable, but we tend to follow hospital-based guidance. So most hospitals will kind of have a standard operating procedure of what those drugs are, what that statin is, what that blood thinner is, what that super aspirin is. Generally, to avoid unmitigated variation, it generally is pretty standardized. I think it's fair to say.
Okay. Are we happy to move on? Chat in if you've got any questions or anything you want to comment on that particular topic that we just discussed. Feel free to ask. Otherwise, I think we move on to the next question, if that's okay with everybody. Which is, this is a good one actually. I like. Oh, hang on, I've got that.
I'm glad we haven't picked a bad one.
So we were talking about standard medications, and this question: do standard medications prescribed post SCA, we can argue whether they're standard or not, but let's roll with it, impact cognitive function or mental abilities? I think this is a great question.
It is a great. I'm actually going to duck it very quickly, because in the chat, Mark Passy, who's one of our ICD doctors, one of our ICD physiologists, has written that ICD and device clinic staff are a really good point of contact. And I would completely agree with him. And I apologize for not flagging that up, because they are a superb, you will have device checks at regular intervals. You can discuss how things are going. Have you got side effects? Have you got problems? And they are very knowledgeable, because they see so many patients with these conditions to be able to. So, when there isn't as good an access probably to cardiologists as there should be, there are a number of other allied health professionals, pacing and ICD technicians, as well as cardiac rehab, as well as pharmacists, as well as general practitioners. So yeah, there's a number of people in the team that can support. So apologies for that, Passy. So do standard medications prescribed impact cognitive function or mental abilities? This is an interesting one. And I think, again, so there is a tiny bit of data to suggest that some lipid lowering medications can have some minor changes on cognition and potentially on risk of diabetes long term. But it is felt that the benefits of reduced heart attack, stroke and cardiovascular death sort of outweigh that. Secondly, beta blockade or beta blockers, so bisoprolol, atenolol, metoprolol, they're all the same. Anything with an olol is a beta blocker type medication. I think there's no doubt that even in patients who have not had a cardiac arrest, people can feel slowed down mentally, not quite as agile, a little bit sort of, sluggish in everything. So I think there's no doubt that beta blockers can do that to you. But again, we have to weigh that up against the benefits that they're almost certainly doing to stop those nasty arrhythmias, to make your heart pump function pump better. The other thing that I think is extremely challenging with this is that, unfortunately, every single patient who has had a cardiac arrest will have inevitably had some brain cell death. So you cannot have a cardiac arrest, even if it's for 3 minutes, for 5 minutes. Bearing in mind, in our centre, the average amount of time that someone has not had their heart beating for is 21 minutes. So 21 minutes of CPR is Mr. and Mrs. average. That is average. So half of our patients will have more than 21 minutes of CPR and half will have less. So I think we just have to be honest with ourselves that the biggest reason to have cognitive malfunction and mental challenges is because you lost a load of brain cells. Does that make sense? We can try and pretend it's a drug that we've given you after the event, but if we're honest with each other, I think the vast majority of damage is done by the cardiac arrest. And even with the most incredible CPR, and we see some amazing CPR, even patients who have very, very minor deficiencies mentally or cognitively, they're still present. Does that make sense? And so, the brain doesn't tolerate lacking of oxygen, lacking of blood supply for very long. And bearing in mind that, as I say, the average patient in the UK will not have a blood supply for 21 minutes. I think it's probably a little short-sighted to try and blame a couple of drugs that might make you a little sluggish when we know that there will be significant numbers of brain cells that are having to relearn things that definitely gives you fatigue, just like in a stroke type patient. We know that you won't have a memory of it for the first 2 or 3 weeks. You won't remember what happened. You won't, people don't recognize people for the first 1 to 2 weeks. When they go home, they haven't got a clue what they're doing, but they can kind of get by and cope. And with OT and physio and being back at home in a loving family, they can kind of get up and running again. But, the brain has taken a big hit throughout all of this. So I would be slightly, and you might say I'm being a medical defensist here, but I would propose to you that the impact of the medications that are given to stop you dying again is extremely small, as opposed to the likely impact of the brain injury you've suffered from having no blood supply for 20 minutes. That's the reality. There, I'm sure, are a number of patients who could reflect and say, there was a particular drug which definitely wasn't good for me. At the moment I stopped it, I got better. But the other thing to say as well is that, as all of you know, time makes you better. Does that make sense? If you look at day 0 and you look at, I say to most people, don't even bother looking at anything until you're a year down the line. When you can look back at a year, you kind of can see where you were in the middle and where you are now. And in most patients, there's quite a phenomenal sort of ramp up and exponential improvement in everything. So don't look back too early, give it a year, and probably don't blame the drugs. It's probably not the drugs at all. I'm not suggesting it can't be, but I think most of the time it won't be.
Gosh, that is a very honest answer, and I think that's a good thing for all of us to hear, actually, Tom. Don't you agree, Gareth? It is. It's the cut. So it's the initial.
Absolutely. And Tom, you're 100% correct about the 12-month thing. 100% correct. We often hear, things like, oh, for the first 6 months we're in denial of what happened. We don't understand what happened. Most of us don't know the difference between a heart attack and a cardiac arrest. Even when we leave hospital, most of us haven't got a clue. And when we look at onboarding volunteers into the charity and that sort of thing, we specifically have a policy that they need to be at a minimum of 12 months post SCA, because we know what they're going to be going through and what they're going to be dealing with. It's only just kind of hit them at that point. So yeah, you're 100% correct, guys. If you don't mind, I'm going to move on. I'm conscious that it's already 20 to 8, and I'm going to move on to question 3. And Sarah, I will tack your question onto the end of that, if it's okay. So question 3, the last one we're going to look the last preloaded one we're going to look at this evening. Since my SCA has already happened once, how can medical professionals reassure me that my heart and arteries are not at risk of another one? And you're not allowed to say we can't.
Okay, so I think there's probably a fairly clear difference here if a heart attack caused your cardiac arrest. I think that's the first thing to say. Yeah. So let's imagine you're unlucky enough at the age of 60, for instance, to have out of the blue some chest pain, a heart attack, which then gets complicated by a cardiac arrest. You lose consciousness, you need CPR, you need defibrillation, you come to a heart attack centre, you get looked after, you're asleep, you get a stent put into your artery, you get treated, and luckily you go home at the end of all of that. The way that's going to prevent those heart attacks happening again and that cardiac arrest happening again is by reducing your cardiovascular risk. So never smoking ever again if you're a smoker, not using recreational drugs like cocaine if you're young and that was one of the causes, ensuring your cholesterol is the best that it can be, and when we say that we mean really low, so less than 3.8 total, less than 1.8 in terms of bad cholesterol, having your blood pressure perfectly controlled, so not being flippant that 135 is okay. No, it's got to be less than 130, it's got to be less than 80. We've got to really adhere to detail to make sure that your risk is low, not being overweight, not being diabetic, or if you are diabetic, having the most perfect controlled diabetes that is possible. And again, the patients that I see, unfortunately, many of them have all of those risks. They're overweight, they're diabetic, they smoke. They have all of these sort of challenges adding to one another, which then after a cardiac arrest and a heart attack can be extremely difficult. But I think it's fair to say that if you, after your cardiac arrest caused by a heart attack, adhere to all of the advice and do all of the right things, the chances of you having certainly another heart attack are low, and the chance of you having another heart attack and a cardiac arrest are extremely low. Does that make sense? Because on all of those medications, beta blocker included, it's extremely unlikely. So I've separated purposefully those cardiac arrests caused by a heart attack, because you can imagine if you have a cardiac arrest because you've got a heart muscle problem or an inherited heart issue for whatever reason that just gives you an out of the blue arrhythmia. Once again, you have to rely on the drugs to keep you in normal rhythm and prevent you going into those unpleasant rhythms that made you collapse with your cardiac arrest in the first place. But of course, generally, you will have an ICD, a defibrillator underneath your skin or within your heart, so that if, God forbid, that arrhythmia does come back and the drugs don't do their job to suppress them, then that you will not die. You might feel a bit strange for a few seconds or minutes while your device does some clever stuff in terms of trying to pace you out of it or shocking your heart out of it if you go into a very fast heartbeat or one that might make you pass out. So I think they're the two big reasons. So heart attack, the best way to stop you having another cardiac arrest because of a heart attack is to make sure you're on all the right tablets, that you control your risk factors as close to perfectly as you can. And if you have it because of a primary arrhythmia, then the best tablets that you can possibly have to prevent the arrhythmia, and then trust your ICD. We also know that ICDs probably won't go off in the vast majority of patients that have them. So I'm pretty sure I'm right in thinking that only about 5% of ICDs in their lifetime ever actually have to do something. Most of them are there as an insurance policy, so that God forbid it were to happen, then you've got your insurance policy right there and ready to go, and that it will kick in and do what it needs to do. But the vast majority of patients that live with ICDs, it will never go off in your lifetime. And so that, I hope, should be reassuring, because again, once you know the underlying problem, once you're then on tablets to prevent that underlying problem sort of coming to the fore, and you've got your insurance policy in place, then you'd be really pretty unlucky. Now, obviously, 5% of people do need another shock, but that's unusual rather than the rule. The rule is 95% of people will be just fine and will go about their quality of life without ever having a problem. So I hope those two things cover most people. But I think the way to prevent things are sort of slightly separated between heart attack causation and non-heart attack causation, if that makes sense.
So you're one of the 5%, Joanna.
I know, I'm very special.
Actually, it's there for a reason, right?
Yeah, thank God it is. Actually,
to be fair, there are also different percentages in different reasons to have them put in. Does that make sense? So I talk about that in a very global population. Depending on your reason and etiology, then there are predictions which can say who some people will be more likely to use it, need it than others, is fair to say.
Yeah, a couple of things then. Livia's just put in one there saying hers is misfired. Misfire is just, in my opinion, just incredibly unlucky. Am I right, Tom? A misfire of your ICD.
Yeah, I mean, I guess Mark will cover this properly because he will almost certainly know more about it than me. But I guess what you want your ICD to do, of course, is sense the correct arrhythmia that is an arrhythmia that needs formal treatment, whether it's with special pacing at a faster rate or whether it's with a delivery of a shock. But what you don't want, because it's just not very nice, is, if you like, the delivery of a shock when it kind of didn't need to be there. And sometimes that can happen with artifact, I'm afraid. So artifact, they've improved things a lot so that artifact doesn't happen very often. But let's imagine on your lead, it thinks it's seeing that ventricular fibrillation, which is just wobbling, but it's not. It's seeing some artifact. Then, you know, there are some algorithms to prevent that from happening. But yeah, look, unfortunately, any technology can have its challenges and sometimes doesn't do the right thing. It's a bit like Windows 95. Do you know what I mean? It doesn't always do it right. There can be bugs, but I think it's fair to say, again, you know, that is an exception rather than a rule. But yes, unfortunately, ICDs can sometimes fire when it's not indicated, but usually there will be a good explanation for it when they go to look at why it happened. But again, it's unusual, but can occur.
So hope that answers that for Livia. And then we've got this from Sarah.
Yes, go back to Sarah's one, so I can flick down. So my ICD, so my implantable cardiac defibrillator, shows that I have VT arrhythmias when I'm asleep. So VT is what's called ventricular tachycardia. And so in general terms, ventricular tachycardia is an arrhythmia that can be dangerous. And so we don't particularly like it, because if it goes quite fast, and what I mean by that is sort of faster than 180 beats per minute, it can make you feel as if you've got palpitations, it can make you feel dizzy, and it can make you pass out. And so ICDs will try and do something about it. So what ICDs will do is that if they see this fast heartbeat coming from the bottom part of the heart going at about 180 beats per minute, the ICD will try and pace you at 190 beats per minute to overdrive pace it, to go faster, and then gradually slow you down to bring you back down to a normal rhythm. And that's one thing that they will do. This is also where beta blockers are particularly helpful, and other drugs too, like amiodarone and other anti-arrhythmic medications. They're very good at trying to stop the substrates, at stopping the ventricular tachycardia. So VT usually comes from a piece of scarring in the bottom part of the heart. And it's the area around where there's a bit of often dead muscle, which in this, they call it this sort of peri-infarct zone. So an area where there's a bit of dead muscle, then next to it, there's a bit of live muscle. And in between, there's a bit that's kind of half and half. And that's where these extra beats come from. And they go in cycles, and often at around 190 beats per minute, which means people don't feel very well. Because if any of us had a heartbeat sitting in a chair at 190 beats per minute, we'd feel dreadful. So the way in which you can avoid them happening again, in all fairness, is twofold. Number one, with your cardiologist, ensuring that you're on the right medications to suppress that. So whether that be a beta blocker, whether that be amiodarone, whether that be other medications, there are other more specific medications, number one. Number two, in combination with that, ensuring that your salts are always, as best you can be, in the right level. So magnesium, potassium, sodium. The problem comes sometimes when you get dehydrated, or where you've had horrible diarrhea for 7 days. Your electrolytes, your salts in your blood can go all over the shop. And of course, cardiac arrhythmias they don't like that. So you're much more likely to have a cardiac arrhythmia when your salts are a bit all over the shop. Drugs can do that too. So you just need to be very, very careful with dehydration, with diarrhea and vomiting, with different medications that can change your salts. That's important. A number of people take magnesium orally as a sort of health shop type supplement, so to speak. Finally, it's really important, and Mark Passy will know much more about this when he speaks about ICDs on another day. It's important your ICD is set to have all of the right parameters so that it doesn't overcool it and it doesn't undercool it, because 180 is often a very sort of, it's a very line in the sand. But let's imagine your VT, your fast heartbeat was 178. Then your ICD maybe wouldn't try and get you out of it. Does that make sense? So if you're having lots of it, what you could do is set your ICD at 170, and then potentially it would see it, do something about it, and make it much less problematic to you. So those are the big things. I think salts, drugs, and ICD settings. The final thing is if people have lots of this scar with lots of extra beats that are very fast that make people feel unwell, despite drugs, despite an ICD, despite salts and the setting, you can ablate the VT. And we have a Neil Srinivasan does that in our centre. Not without risk, but in certain patients where this is a big problem, you can try and burn away these areas that are causing the ventricular tachycardia. So I hope, again, that sort of summarizes, without being too bespoke, about the possibilities of why this might happen and how you might minimize the chances of it happening again.
Fantastic. Thank you very much. I love the fact that Sue Chapman's ICD is called Chip. I think that is absolutely inspired. I know people like to have nicknames for them, but I just love that one. Super lucky, yeah. 5 SCAs and 4 saved by the ICD. That's why they're there. That's what they're there for. Okay, so we're coming up to sort of 5 minutes to go. We did say 7 till 8, and I think we've gone through the 3 questions. We've gone through the questions from chat. Joanna, I don't know if you've got anything else you want to ask or to add.
I just wonder if it's appropriate to mention what Mark has written at the bottom. He says, when we were talking about the inappropriate shock, he said 5 to 8% inappropriate shock rate in modern ICDs. Unfortunately, it's quite low, but compared to 30 to 40% in the early ICDs, which were he said most often caused by fast arrhythmias from the top of the heart. And perhaps it's a good follow-on, Gareth, for you to mention about Mark. And
absolutely.
Yeah, you're on it. Okay.
Yeah, absolutely. So this is this SCA UK Live. This is a series of live streams. We're going to be running them every 2 weeks on a Tuesday evening at 7 p.m. And the next one is lined up already, and that will be on Tuesday, the 23rd of September at 7 o'clock. That episode is called All About ICDs. And we are very, very blessed to have Mark Passy, thank you, Mark, so much for joining us this evening as well and being in chat. But Mark has agreed to join us in 2 weeks' time. He is an expert on all things ICD related. And he was kind enough to speak for us at the conference in Hinckley in May. And I have to say, he probably got the best reviews of any speaker we've ever had at any of our conferences. So I can't recommend him highly enough. If you don't attend any of them, attend that one. So yeah, that's going to be in 2 weeks' time, 23rd of September.
There is a question in there, Gareth.
So yeah, I will just try and bring that up. There we go.
Yeah, that's fine. So so the four types of drugs which are generally the pillars of people whose heart function is not normal are beta blockers. So bisoprolol is the commonest, or carvedilol. So beta blockers, number 1. Number 2, a medication like an ACE inhibitor or an ARB, and that includes sacubitril valsartan, an ARNI. So an ACE inhibitor, an ARNI, or an ARB. Then a dapagliflozin, which is historically diabetic drug, but has got some fantastic data for heart failure, for kidney support, and improving your heart function. And finally, a drug, either spironolactone or eplerenone, so mineralocorticoid inhibitors. They are the 4 pillars which, if your heart function is not normal and you have a diagnosis of abnormal heart function, then all 4 of those will ensure that your heart pumps better for longer, with less complications of heart failure, admissions to hospital, and complications and death. So they really have, over the last, I would say, 7 to 10 years, completely changed the way in which heart failure is viewed. So not that long ago, so 10 years ago, say, when I was just sort of starting out as a sort of senior registrar consultant, it was a much more miserable condition than it is now. We really do make people better, get them home, and they do have many, many years or decades of really high quality life on these medications, which support their heart considerably. So, yeah, I think we're in a much better place now.
Tom, can I just ask, because my first cardiac arrest was caused by a heart attack, and that was 12 years ago. And I got on reasonably well with the medication, and it's, apart from, okay, I had a stroke, so one of my drugs was changed, but nothing else has ever been changed. Because I don't have any sort of negative reaction to it. How would I know that, maybe I would be better off now on a different medication? I'm talking generally, not specifically about me, but somebody that had a cardiac arrest or a heart attack that caused cardiac arrest 15 years ago, they're quite happily taking their beta blocker, their statin, their, and they've got no idea of this drug that you just mentioned. How would they find that?
No, it's a really, really good point. And not being funny, in my clinic, I will see a patient who I've looked after for maybe 10 years, 15 years, and I'll look through the medication and go, oh, you're not on a so-and-so drug, because it came out with data 2 years ago and I haven't seen you for 3 years. And then I will start it. So you're right. I mean, there are some, just to reassure people, general practices are going through databases, looking at people with heart functions that are not as good as they should be for whatever reason. So, heart failure with low ejection fraction, and they are case finding. So let's imagine, just as you described, a patient from 12 years ago isn't on those 4 because those 4 didn't exist 12 years ago. Mm-hmm. There are efforts to try and find patients like that to ensure that they are on the most contemporary medication treatment. So whether it's never going to be 100% effective and find everybody, but just to let you know that there are general practice pushes to get everybody onto the right medications. And not only that, and the reason why is because they are reimbursed for doing that. So, but at the same time, that's good for the patient and good for the society in terms of having patients on the best possible treatment so that they have the least possible problems and the best outcomes.
Fantastic. Thanks, Tom. Thanks for that. Right. So we are approaching the end. We did say 8 o'clock because 2 of us here are cardiac arrest survivors. So we have all the same problems that everybody else does with fatigue and concentrating for more than an hour. It's a bit much for us. I do just want to quickly add, guys, October is Sudden Cardiac Arrest Awareness Month. And at SCA UK, we are holding a whole host of regional meetups, which our regional representatives are working away on right now. They will be on the Saturday, the 4th of October, starting at 2 p.m. And we've had a fantastic response. So I apologise if I'm looking away, but I'm reading on the screen. We've got meetups organised in Yorkshire, North Wales, South Wales, Bath, Gloucester, Abbotsbury, West Midlands, London, West Scotland, Northern Ireland, South Central, Southampton. They're all over the place, and there's more coming day by day. So the reps are doing a great job. If you've never been to one of our national conferences or regional meetings, if you can make it, we're trying our very best to get them all over the country. And as you can see, we're also in Wales, we're also in Scotland, we're also in Northern Ireland. So if you do get a chance to get along to one of those, I don't know about you, Joanna, you've been to several, I know, but I don't think we can recommend those highly enough.
You cannot. Nothing beats actually being with other people who get it. I think we all agree with that.
Yeah. Okay, and with that, I am going to wrap it up for this evening. Tom's probably got one eye on the football, which is just about to kick off. So
I don't know why. Yeah.
So yeah, first of all, Joanna, thank you. I know you're going to be with me again in a couple of weeks' time, along with Mark, and Professor Keeble. Thank you so much. Really, really appreciate you
Anytime.
taking. Thanks, Sue.
How lovely that was.
Just one last thing. If you have enjoyed this evening's live stream, it will stay on YouTube. You will be able to go back and view it again. So I can't remember. I think Sue, who asked about the name of the drugs. If you didn't get a chance to jot it down or whatever, it will be there. You can go back and relook at it. But if you did enjoy it, please do subscribe to our channel. Do give us a thumbs up on the video. Do share it. All those kind of things. Not for us, but it gets us up the YouTube algorithm ladder. And the more we get up the ladder, the more people we can reach, the more people that we can help. And that's ultimately what this is all about. It's all about helping as many people as we can. In the next 12 months, there's going to be another 2,500 families in the UK affected by cardiac arrest survival, many more by non-survival, sadly, but there's going to be 2,500 people that, as of right now, don't know what's about to hit them. And we need to be there for them, and they need to be able to find us. So it's important to do that. And I'm going to wrap that up for this evening. You will notice on the outro video, there's a couple of QR codes. One is to enable you to donate to SCA UK. One is to enable you to buy something from the shop. You don't have to do it, but I do have to put them there. So thanks for that. Thanks, Joanna. Thanks, Tom. And we'll see you on the next one. Good night.
Bye. Thank you.
Bye.
Why is it not playing it?